thrilled to welcome a good friend and a colleague, Anaeze Offodile. He is a breast cancer surgeon at MD Anderson. I've gotten to know him over the last several years, and he's just doing really great stuff there. So by way of biography, he's the executive director for clinical transformation. He's also an assistant professor in the Department of Plastic Surgery. His clinical specialty is breast cancer surgery. And he also conducts health services research at MD Anderson Cancer Center in Houston, Texas. He is a non-resident scholar in domestic health policy at the Baker Institute, which is a nonpartisan think tank at my alma mater, Rice University, just across the street from the medical center. In his enterprise role, he is tasked with integrating digital health technologies into the organization and delivery of cancer care with the goal of improving outcomes. He's an accomplished scholar, and that scholarship is focused on optimizing cancer symptom control, characterizing the risk factors for financial toxicity following cancer care, and conducting a systematic examination of the organization and financing of surgical care delivery under global capitation payment arrangements. He's a graduate of Kent State University, Columbia Medical School, and Johns Hopkins School of Public Health. He completed a surgical training in general surgery at the Brigham Hospital in Boston, Leahy Clinic for Plastic Surgery, and then a microvascular fellowship at MD Anderson. He's on the editorial board of the Annals of Surgery. He's the recipient of competitive extramural funding, and we'll have more to come soon, I'm sure. And is published in journals such as the Journal of Clinical Oncology, Nature Medicine, Lancet, Annals of Surgery, JAMA Network, Open JAMA Surgery, JAMA Health Forum, and Health Affairs. He was the 2019-2021 Gilbert Omenn Fellow at the National Academy of Medicine and was an academic collaborator with the National Academy's Committee on Emerging Science, Technology, and Innovation in Medicine. So, looking forward to hearing about all this work, and thanks for coming to us in St. Louis.
Absolutely. Can everyone hear me? Okay. So thank you, Tom. So I titled my talk somewhat provocatively, "What's a Hospital Without Walls?" It's also a nod to the fact that healthcare is really a policy chassis, for lack of a better word, and Hospital Without Walls is a CMS waiver during the pandemic that drove a ton of the things I'm going to talk about today. So, I phone a friend and get tired. So what I'll show next is COVID, right? Certainly upended many things, sadly. But another thing that came with COVID, we can all agree, was it was a massive forcing function for digitalization of how we do care. Thank you. So this slide came from McKinsey. So it's not, necessarily an academic source, but certainly credible in this area. And you can see sort of peak COVID, there was this, logarithmic spike, and it sort of settled down. But relative to January was still 38, 40x of where we were activity-wise with respect to sort of telemedicine utilization. And in many ways, we think of this as a proxy for a larger shift in healthcare. So what does that mean? That means that we think that this will stick for many reasons. One, as the pandemic was still in it, the pandemic evolves to an endemic state. That time allows for patients' preferences and attitudes around virtual care to entrench. Number two, sort of the broader canvas is that how we date, how we get transportation, how we travel, how we consume content is digital, right? You could also reframe this slide, this point number two, as the world's biggest taxi fleet, the world's biggest hotel chain, the world's biggest sort of like media companies don't have any physical assets, right? So our world is increasingly virtual, decentralized. And I'll argue that with the demographic shifts being that in the next 15 years, the bulk of the healthcare workforce and patient mix will be millennials. I think these consumption patterns will only intensify moving forward, right? And I think COVID did not really create any new trends, it just sort of pulled it forward, is how I think about it. And also, not into my slide, my talk, there's increasingly a permissive regulatory climate around sort of telemedicine, hence hospital without walls, hospital at home. And last but not least, there's a lot of private capital following this regulatory climate. And you're seeing new business models, new entrants, new players in this space that will not go away. There's Amazon, but there's CVS. And speaking to my first point, so this slide sort of calls out patients' attitudes, and so circa 2002, with respect to where they get their care. And just quickly, the take home is that in gray was baseline, in orange or green was post-COVID or due to COVID. And you can see that every other site of care, retail clinics, doctor's offices, sort of decayed from a patient preference standpoint, except for virtual care. And I'll argue that this shift is probably past 50% as the longer the pandemic goes on. And speaking of private capital, you can quickly see that sort of, the last slide was just showing the levels of sort of digital health related fundraising and investments. So it's going up. And, we're inflation, likely recession, interest rates are up, but still, from what I've seen for 2022, still significant. And where's the money going? Oncology is in top 5. Not a surprise. It's the second most expensive chronic condition. People are getting older. People are surviving more. So there's a ton of spend in oncology, and this reflects that. So when we think about what's the next chapter of virtual care, one thesis that I think has significant purchase is this idea that, first of all, virtual care is not homogeneous. So there's a lot of gaps and sort of a mismatch in services and need. And that plays out specifically for specialty care, surgery, oncology. And you can see here in the green and in the orange, huge splay, huge band of sort of where virtual care access sits and where there's a demographic need. And you can see for surgery, which is what I do, and for oncology, which I'll lump in specialty care, huge variation and need by demographics. Unfortunately, it plays out like we've seen from an equity lens, so low income, racial minorities, massive need for these services. And I think virtual care will sort of intensify in these areas because that's what the need is, certainly in oncology. So in oncology, sort of trends, people think that you'll play out in sort of end-of-life care, chemotherapy. And I'll point out that Penn Abramson has done a ton of work with respect to decentralizing chemotherapy infusions, pre-pandemic, but certainly more after the pandemic. And also acute care, sort of where we think about receipt of acute oncology services, whether it's chemotherapies, therapy, more and more ambulatory with a digital wraparound, right? So we'll never do radiation therapy at home, but can we decant parts of that care journey to the home setting and as appropriate leverage the brick and mortar? So that's sort of where we see the shift of how virtual care and oncology will play out. Time horizon of 5 to 10 years is what people say. And I think this is actually quite spot on. So we've thought about this and say, okay, what we do at Anderson, what would that look like in this new sort of digital world? And we think it will play out in really 3 ways, driven by COVID. 1 is virtual care, which will be the bulk of today. 2 is advanced care planning. We think the sort of suddenness in which COVID hits, so sort of like there's no rhyme or reason to who gets it. And thinking back to 2021, 2022, there was so much uncertainty as to disease trajectory, available treatments. It really forced many cancer patients and their care teams to really sort of, once again, pull forward advanced care planning in a systematic way. The last thing you want is for someone to be intubated in the ICU and no one knows sort of what's going on. No one knows if that was consistent with his or her preferences. So it really pulled forward advanced care planning, and I think that is for the better. And lastly, this idea of decentralized trials. So this is something that intellectually I'm very excited about. I'll say, a few argue that the traditional research infrastructure is broken. So like most patients don't have access to trials. They have to come into the mothership to get access to these cutting-edge treatments. Minorities tend to not access trials. Trials tend to run longer, overrun cost-wise. So virtual trials is basically thinking about the assets of virtual care and hospital home to support a trial infrastructure. So that is the lab draws, the imaging to be done in a community, but just decentralizing trials from an AMC like WashU and Anderson and embedding in the community. So that is something that's really driven or taken off post-COVID. It's pretty exciting to see how that continues to evolve. So that said, a lot of good things with virtual care. However, a gap still persists. So I found this slide particularly interesting. So, the majority, 34%, 3/4 of patients, so they prefer some digital intermediary with their care. However, only 1/4 report using them. So that gap, to me, points to an implementation gap, right? So there's a need there on patients. We have the tools, most places do, but why does that persist? I think it's the way we roll these things out and implement them. Now, partly because the pandemic was such a sudden thing, so we went from 0 to 100 to respond to the public health emergency. So we don't have the time to think through and say, okay, what works, what doesn't work, what's the right context, what's the right tool? And I also argue that the evidence base for a lot of digital innovations was not robust pre-pandemic. Right? There were signals, intuitively make sense, but there was not a ton, certainly in oncology, besides remote patient monitoring for symptom control, that sort of digital care writ large, scaled, enterprise-wide was the right thing to do, to be totally candid. So I think the thoughtfulness on how we deploy this, once again, there's a public health emergency, but now that we've sort of moved from a reactive posture, I think health systems are now beginning to think, okay, how do we bake this into our clinical workflows and think about the patient segments that this will really help. So along these lines, we sort of documented how we approach at MD Anderson, sort of what's our framework to embed virtual care in our clinical workflows. And we call this framework DIBS, we gave it a mnemonic, and it really rests on sort of 4 main things. One is documentation dissemination. So we're thinking about implementation science in how you roll these things out. 2, integration is how do you sort of minimize redundancy and so really big this into existing workflows, or if the workflow does not support virtual care, you drop it and make a new one, right? So we've been very thoughtful, and in this paper, we sort of used the example of a clinic visit, sort of in-person and virtual. Where are the commonalities that should remain, and where are the parts that should be dropped for a virtual encounter to optimize that encounter? The third thing is best practice. So like everyone is doing 1,000 things, we're writing about it. So teasing out, sort of scanning the ecosystem and saying, okay, what works, what doesn't work, why, and what can we import to our system? And the last thing, critically, is infrastructure. So in many ways, we're in a new virtual care environment, which means that new things need to be stood up to support it. Sometimes you can easily translate an in-person infrastructure to the virtual, but sometimes actually you need to stand up something de novo. The next slide speaks to an example. So thinking about sort of holistically, what type of new infrastructure should we get to support this new virtual care environment? So one that we've stood up at Anderson is this idea of digital health navigation, right? So it's not patient navigation. It's actually thinking about, for a patient encounter, what type of support for patients and providers could optimize the workflow. So this is an example of a job description for our digital health navigator. I'm just sort of focused on the screen right, and you can see thinking about sort of monitoring adherence with the platform, creating best practice, helping with workflows, assessing for digital literacy, right? It's not 100%. Actually, it's very, very variable. So trying to right side the technology solution to the patient and caregiver in front of you and seeing what makes sense. Keeping up with documentation, and obviously the regulatory space is moving very rapidly, so keeping up with that. So these are all sort of the things that sort of the person who would fit this role does not exist today. So think about new infrastructure to support virtual care. We think things like this need to sort of be brought to bear. So it's an example of support under virtual care that we've sort of stood up, the team did at Anderson. So as we think about the future, we think that virtual care should be sensitive to patient preferences with respect to where, how, and when they get cancer care. So for instance, virtual care is not for every patient. It's not for every encounter for a patient who's amenable to virtual care. So really being nimble in how you roll this out is something we're really thinking about. And to be honest, leveraging implementation science frameworks and how we roll out virtual care with partners in the UT system is something that we've really leaned on in the last 18 months or so. So give an example. So the first project that I'm going to speak about is remote patient monitoring. So it means different things to different people. But for us, I'll tell a story. So a patient with advanced solid tumor is about to start chemotherapy. And we've created algorithms to flag him or her as high risk. And then in this new paradigm, we've created sort of a digital navigator before he starts chemo, engages, let's call him John, about the program, our remote monitoring program, and sort of sets expectations and says what is intended to do and how it fits into his or her care. And then for now, it's done on a clinical trial basis. So we get consent of the patient and or caregiver as appropriate. And then we start John concurrently with chemotherapy and remote patient monitoring. So in our context, it's patient-reported outcomes as well as biometrics. So many chemotherapies have different side effects profile, very disruptive physiologically. So with great humility, I'll admit that the evidence base for biometrics does not exist, right? It intuitively makes sense that sort of a patient with a PRO that is concerning for dehydration in the context of biometrics that show tachycardia and low blood pressure, that heightens the sensitivity. But is there more noise getting all this information into the ecosystem? So what is done in a trial, but for our paradigm, it's biometrics and PROs, protocol driven. So once a day, set time, we sort of establish a baseline biometric for John in this story, and we track him or her prospectively. And then all this information flows into our EMR Epic in real time and is actively surveyed or triaged by a dedicated nursing team. So these nurses, once again, think about infrastructure. They've gotten training on symptom management with our palliative care service. We use sort of NCCN, Comprehensive Cancer Center Network guidelines to sort of walk through, should a patient call with a neuropathy symptom, here are the things you should do over the phone. We've created workflows with respect to when will you call into the primary team, when will you have them come into the ER. So in many ways, I think the big lesson is virtual care is real care, actually. And in many ways, it's technology wrapped around everything else that we do, right? Nurses, workflow, protocols, pathways. So that's our program. Why do we do this program? We think that proactive high-frequency monitoring does several things. One is a connective tissue to the patient that doesn't exist if they didn't have this sort of virtual care wraparound. And number two, we do think that if you could flag and intervene on symptoms before they escalate, then sort of that translates to better quality of life, less ER visits, less hospital admissions. And in our program, so they get a box that has biosensors, has a tablet. On that tablet is loaded educational materials about the chemotherapy, about the cancer. So it also drives or could improve patient self-care. And this is canonical work done by Ethan Back, where he showed remote patient monitoring defined as just PROs improve ER visits overall survival. So we're saying that our program moves the needle forward by adding active nurse-led surveillance daily, so high-frequency reporting, and vital signs. Could that probably reproduce this finding or maybe improve on it in our population? So this was our typical RPM patient. Once again, we're done in a trial. So we had for the pilot and now for the RCT, which is ongoing, we had clear inclusion and exclusion criteria as listed here. And we sort of said, okay, who is the typical high-risk patient? So we leveraged data published and we iterated that for MD Anderson. So for us, who could be high risk based on the typical phenotype of our patients? And we sort of came up with this co-design with sort of medical oncology. We came up with these criteria to sort of describe who's high risk. Because once again, we can never scale this infrastructure to all our patients. The volume is just prohibitive. And also, once again, I think as we think about what virtual care should look like, think it should be very targeted, So there's precision oncology. We think of it as precision delivery. So the right patient, the right intervention. And part of that right sizing is coming up with who should get this intervention. And we did a pilot, we finished the pilot, and this is sort of the proof of concept pilot. 1 month, I'm really thinking about workflows. So we launched this program last year, doing a surge in the greater Houston area. So what that meant was we had to sort of adopt a completely decentralized virtual workflow. Which we've completed. So that added complexity necessitated a pilot. And this is sort of the typical pilot journey. This is the care team. Once again, the clinicians who sort of help confirm appropriateness for patients. But the bulk of the work is done by the digital health navigator here. And these are all the roles he or she, for us it was a he, sort of really quarterbacked this program. Tracking adherence, reviewing potential patients with the care teams, onboarding patients and caregivers, sort of feeding back the PRO data to both the patient and care teams in real time, and also tracking sort of experience during the program. And obviously, a key member was the triage team as well. This was our program, and so what the dashboard looked like. So basically, it was in real time. This was accessible to the triage and the digital health navigator. And by design, our workflow was to keep the primary team in the loop, but really care was really driven by the nurse triage. So when we think about sort of virtual care and all this data flowing into the system, one thing we're sensitive to is this idea of worsening provider burnout, right? But now with this program, all that information flows through the nurses, and we only feed back to the primary team what is absolutely critical. And everything else is protocol managed and triage appropriately. So this is our dashboard. And if we preset alerts to PROs and biometrics, and if it triggers, it will flag via email to the navigator and triage team, as well as alerting on the dashboard. And then from then, typically there'll be a call, the platform supported video visits as well, and engagement, and so on and so forth. And sort of we published our protocol already, and the workflow just showed the completely virtual workflow. So everything from onboarding to shipping the kits to getting the kits back to the engagement was completely virtual. That's how we designed it. And circling back to decentralized trials, this showed us that in many ways the assets for virtual care delivery can and should support of a research-based paradigm. And in many ways, that pilot is a decentralized pilot study, and the ensuing now active RCT is hybrid. So as appropriate, you just flex into virtual or in person. So how we define success was listed here. Fundamentally, it was a proof of concept pilot. So we defined success as really enrollment rates. So for our virtual workflow, how many did we approach who we converted to a consenting patient? And also how many patients sort of at the end found that program acceptable, appropriate, and feasible. And then we also had other sort of outcome measures that we tracked as well. So going to the results, it was over 9 months, and we enrolled 36. Our target was 25, so we just sort of kept on enrolling until we got to our target. 11 stepped out. Of the 11, none ever put in PROs or biometrics. They either transitioned institutions, or they came off chemotherapy, or went to hospice, so we sort of pulled them out. So every patient who started reporting PROs and biometrics completed. And the protocol was for once a day, 5 days a week, between 8 to 8 p.m. Towards the end, based on the feedback, we actually extended to 7 days a week, which is what it is now. And you can see sort of the trajectory of enrollment, just age distribution, gender breakdown. We're very sort of thoughtful, or intentional, I should say, to think about sort of virtual care. People interact with it differently. So we wanted to have a good mix of the young, middle age, and the elderly to sort of get a more reliable impression, because as we scale this, we will affect all these age demographics. So getting a representation of race, gender, age was very important for this proof of concept pilot. And then looking at the alerts, so interestingly, biometrics drove a ton of the engagement. Now, this could be more noise than signal. So we did update the thresholds for biometrics mid-program, but certainly drove a ton of the engagement. And a lot of the alerts were actually high alerts, so sorry, medium alerts. But we still had a fair bit of high alerts as well. So going to the outcomes, so we use a Likert scale. So there's a Weiner implementation of instruments called the AIM, FIM, and IAM for appropriateness. And usually you want to get above 3.5. You did really well with that. And thinking about the logistics for this program, we sort of settled on by the end about a 1 week between flagging a patient in the sort of upcoming EMR schedule for an oncologist and them getting a kit at their house and starting treatment. And the system usability scale, which is an assessment of the ease of use of the platform, was pretty high. 68 is sort of what people look to. We got an 88, so we're pretty happy about that. So in surveying patient satisfaction to the roof, we're pretty happy. Adherence rates, we aimed for 70%, we got 73%. So what this means was over the pilot for 1 month, these people sort of met over 70% of all their prompts, PROs and biometrics, i.e. they put in sort of this information every day as protocol driven the entire time. We're pleasantly surprised. And I think the reason, and we did a bunch of testimonials, but it became very clear for many patients, this was care, right? They and you see the quotes, they really experienced this as almost equivocal, not quite the same, obviously, as inpatient care, as in-person care, I should say. And that really drove the engagement. We looked at our, once again, it wasn't powered for this, but we could not help but take a peek under the hood. And so far, the signals are reassuring that from an ER or acute care realization standpoint, these things actually is a signal for it. And our RCT is powered towards ER visits. And then once again, not powered for this, but also a signal that there could be some survival benefit when you look at those in the pilot program. The control for this was people who came to the, started or consented, but we could not get them on board. So the 11 people who went off, or those who refused, or those who were eligible, but we could not reach them. Either we called them or could not get them in clinic. We just sort of prospectively followed those patients on an IRB. So that was our control group. So for those people who were high risk and appropriate for the program, that was their ER visitation rate. And this was their like 1 year survival outcome. Once again, signals, once again, it's not powered for this, but signals that we'll see what the RCT would show. And, you know, so certainly thinking about as a service, you know, we've obviously surveyed many dimensions of it, but one thing that we're pretty happy about for a pilot is that people thought the experience was phenomenal. So we used a Net Promoter Score, got a very favorable score, and these are quotes that sort of people gave us. We had one, so in spirit of full transparency, we had one patient who didn't get it. And her quote was, out of 25, she thought that it was excessive. So that sort of called to us, is our frequency of the PROs and biometrics too frequent? I will say that we workshopped the program before and after with a patient family advisory council. And they thought it was sort of, for our intent, they thought it was reasonable and acceptable, and so did everyone else. But full disclosure, one patient did think it was a bit excessive because she had no symptoms. She had a very uneventful sort of chemotherapy course. So you can imagine for that context, she made a reasonable response. So I think moving forward, we'll be able to titrate the dose, for lack of a better word, of the intervention to the patient's story. So that's where we are with the pilots. Where we are now is we've launched phase 2. So we've completed the staffing model with digital health navigators. We've launched phase 2, which I'll talk to in a second. We are going to try to automate the screening process. So for the pilot, two labor-intensive roles were, one, going through the clinic schedule to flag a potential patient and servicing that to the oncologist, say, is he or she appropriate, yea, nay? And given the volume, so for instance, our GI center sees over 6,000 patients in a year. So that's just like prohibitive. So we have partnered with a startup called Deep6 to just basically use NLP AI to just screen, to just literally identify patients who meet our criteria, automate that process. The next part we're doing now is actually creating AI algorithms to give risk scores for who's high risk. So now we're only really engaging the oncologists with people who we think are truly, truly high risk. And if they disagree, they feed back to us why they disagree with the assessment, and we feed that back into the AI engine to update that. But that work is ongoing now, and I'll talk about point 4 later on. So the former program is a pragmatic RCT. Like I said, there's existing evidence base for PROs alone. Biometrics is sort of new, and we're enclave that adds value clinically. So the RCT is usual care to PROs alone to PROs plus biometrics to establish that whatever gains we see there's a marginal gain from biometrics, and it's not all driven by PROs alone. So that's where we are now, and this is launched about a few months ago. We're pretty excited to see what the results will bring. And now our outcomes is powered to ED visits, but now we're tracking caregiver burden. So once again, with virtual care, an unintended consequence could be, are we passing the burden of patient management on to caregivers? From the nurses, to physicians, to fellows, to spouses, siblings, loved ones. So we're tracking caregiver burden as well. And from the patient standpoint, we're using PROs that are cancer specific and overall quality of life, so MEDACI and FACT-G. And this is what we're doing. So for the RCT, it's GI and thoracic med-onc. And this is our outcomes. Most I've talked about already. We're also looking at ROI. So digital health navigation, hard funded. This program is hard funded. We want to make sure from a financial prudence standpoint that actually there is indeed ROI back to the system. So we're tracking that as well. And should we show benefit? And I think it will be a qualitative judgment of, so, how do we perform on all these various things, with ER versus being our primary outcome? But there'll be a decision gate to scale or not based on how we perform with the RCT. And then it will be first horizontally with other solid tumors, and then we'll sort of transition to liquid tumors, and then potentially other non-med-onc use cases, in my world, surgical oncology as well. So that's how we're thinking about it. And then it's sequential here, but actually it's somewhat concurrent. We're also thinking about, well, what could hospital at home look like in this context? And we think this work is important because in oncology, there's a ton of therapeutic innovation, our T cells, checkpoint inhibitors. But Everett Vokes, who was the outgoing ASCO president this year in his plenary, really spoke to where I think where cancer will be headed in the near and long term, which is it costs a lot of money, second to cardiology as the most expensive chronic condition. But we need to begin to bake in delivery innovation on par with therapeutic innovation. And he really echoed his comments. As we think about being innovative in how we serve our patients, is as much how as it is who. And one thing that we are passionate about is this idea that should we be more intentional about how we diffuse innovation in the ecosystem. And potentially innovation could be a force for equity if we're deliberate about it. So what we've done, and it is grant funded, is really take the chassis of what I just talked about at MD Anderson and transfer that to Harris Health. So Harris Health is the treatment provider for the greater Houston metropolitan area. And we basically took our entire program and iterated it to the Harris Health context. And it's been a huge learning experience for me and our team with this whole process. The first one being that, number one, in many ways, healthcare is, I would say, paternalistic and has a perverse power imbalance. And as we now bake an equity lens, the first part of that should be a partnership. and really partnering with these communities. Who are we to say what this should look like in a safety net context? So what we did was, one, we stood up a patient advisory board, paid them, and really had them upend, evaluate our protocol, and redesign it to be more meaningful to this context. So what does that mean? It means our primary outcome for these patients is actually not so much ER visits, we are tracking that, but it's actually treatment disruption. They found that to be much more meaningful. Think about it, most patients don't go to healthcare to minimize 30-day readmissions. They don't even know what that is, right? It's not a patient-centered outcome. It matters to us, it matters to payers, but if you really want to center care from the patient's perspective, then the outcome should reflect that. So for this, it was, treatment disruption. So once again, reconsidering who the experts are, accounting for the context. Example of that, then the Anaeze, given our patient mix, a lot of them are very sophisticated, tech savvy. For the LBJ, all our kits came with mobile hotspots because these patients can't afford Wi-Fi. They don't always have Wi-Fi. So we give them Wi-Fi. We sort of provided it in different languages as appropriate. So there was a ton of iteration to the context that, quite frankly, if we did not do, it would probably make this not successful. So that was pretty important to us. And also thinking about sustainability, I spoke to it at Anaeze, but it was also critical at LBJ. And one thing that we've also done under the grant is to actually do a concurrent, it's called a hybrid type 1, implementation analysis of the program at LBJ and MD Anaeze from a contextual driver, barriers, facilitators, stakeholder interviews. And the goal, what we promised the funder, Rising Tide, was we'll give you an RCT result as well, but also a cookbook on how to do remote patient monitoring at a safety net and how to do it at an MD Anaeze. So this is how we did it. And then with that information, other entities can right size as appropriate to their context. So that's work that we have going on now, and work that is a bit frontier, but certainly we're very much designed and looking forward to kicking this off, is sort of hospital at home, care at home. So this is a program that's really taken off with the pandemic. So CMS, to account for the surge in COVID and sort of thinking about the inpatient bed capacity, sort of created the acute care at home waiver. And what that waiver did was, one, waive certain provisions. One is 24/7 nursing, availability. One is a fire code for the home, but waive certain provisions to allow and pay for care in the home, acute care in the home. So in this new waiver, which is still active for now, is the equivocal DRG for pneumonia is reimbursed at home as it is in a Barnes & Noble, Barnes Jewish bed. So you can imagine that incentivized massive uptake. But what is hospital at home? It means different things to different people, but I think sort of the canonical descriptor is this paper by Bruce Leff out of Hopkins, who sort of brought this program here. So right now in Australia, about 6% of all beds for the last 15 years have been a hospital home bed. So it's actually not new. It's been going on all over the world for a very long time. Bruce brought this to the States at Hopkins. And I think this is a commonly accepted set of definitions. One is an acuity and intensity of services that will otherwise need inpatient admission. So if it's chronic care at home, that's home health, that's not hospital home. And hospital home requires intensity, labs, imaging at the same frequency that is not commensurate with home health. Two, for operational reasons, there needs to be a pre-specified geographic catchment. So should care need to escalate, you don't want to be driving an hour in, you want to be sort of within a certain region. So there's typically is about 30 minutes to 45 minutes from the main brick and mortar facility. And lastly, 24/7 coverage availability in the hospital home. And this is where remote patient monitoring sort of fits into this model. So this is what it could look like. Once again, I'll say post-COVID, hospital at home has been more technology driven. But the idea is if patients at home and they have on-demand meds, labs, skilled nursing with, in the brick and mortar, staffing model of MDs and APPs, while nurses, paramedics go into the home under the direction of a clinician to deliver care. And usually it's about twice a day. Could titrate, but that's the expectation. And that is a decentralized model of care where you're treating patients in the context of their lives. Pre-pandemic, there's a pretty strong evidence base. It wasn't big, for full disclosure, it wasn't big, but it was there. So there's about one RCT out of Brigham that sort of pre-pandemic that was pretty compelling. So you see these levels of length of stay reductions, readmission, quality of life, other operational metrics, as you'd expect, through the roof. And you can imagine post-pandemic, the way we think about it is there are many, many natural experiments going on right now in the US post-pandemic. The way we think about it is for patients, payers, health systems, so a lot of value creation, left to right, convenience, less iatrogenic events because you're not in the hospital. With humility, I will add that there are probably new types of iatrogenic events in the home, just don't know it yet, but certainly it's less likely to be delirious if you're in your familiar home, familiar bed, familiar environment. For payers, it's a lower cost structure because there's no fixed cost of a hospital. It's all variable costs delivered to the home. I would say that until you scale, you probably will not get those variable cost benefits until you really scale. And you know, most hospital home programs pre-pandemic were paid on a bundle case rate, actually. So it lends itself quite nicely to value-based care arrangements. For health systems, so these things listed here sort of make sense. Market differentiation, optimized care transitions, right? It's hard to be readmitted if you're delivering care in the home, and you can certainly use the infrastructure to optimize follow-up with the primary team and touch base or feedback loops with patients. And it helps with the occupancy capacity issues, which many people were struggling with pre-pandemic. And I'll probably say the most compelling thing, or one of the more compelling things, is when you look at sort of the inflation trajectory in the US over the last 20 years, hospital services by far and away was like, you know, it jumps right at you. It's just more expensive, and I'll say unsustainable. And when we think about Medicare Trust Fund Part A and just the insolvency risk, it kind of makes sense that payers, specifically Medicare, regulators will be looking to this model and more so moving forward. Now, what's hospital home within an oncology context? I'll say it's about the same thing. So this idea of a technology-enabled delivery model for hospital-level services in the home, narrow criteria for eligibility, clinical protocols, but use cases could be end of life at home, could be chemo, IO therapy at home, a la Penn, could be a hospital substitution strategy, which is sort of our framework, or it could be an ER avoidance. So could you deploy these services or have them available to be flexed should a patient that you're remote monitoring in the home begin to sort of like escalate? Instead of having her come into the ER or him to be evaluated, you deploy hospital home to that person and optimize as appropriate in that environment. So this is what it could look like, right? So the patient, remote patient monitoring, and let's say they begin to have nausea complaints, right? So there's a protocol, there's a pathway, nurse engages through RPM, you can manage that. But let's say it escalates, and let's say it's concerning for something more. You now flex in hospital home into that setting, provided they're stable, and you get labs, give fluids, do a KUB, have a nurse examine him or her in the home, and as appropriate, you could definitively take care of it then, or escalate to the hospital setting, non-urgently, somewhat managed, scheduled to deal with it. So this is almost like an ecosystem that you can sort of flex in and out of between remote patient monitoring, hospital home, the same providers, the same chassis of protocols and digital capabilities sort of come to bear. Just the intensity is different as you go from one to the other. And that's sort of how we think about what our position, as to what this could look like moving forward. Right? What building it, it could change, but the idea is to minimize the friction. So if we go back to this prior slide, this patient, I would say this wraparound care without walls, certainly I think is an advance on what's happening today. And we hope we could make it reproducible and scale it across other conditions. And what we hope is for status quo, with remote patient monitoring, we'll get these types of benefits. And hopefully with hospital at home, which we're calling remote supportive oncology at Anderson, you get even more directionally. And when we think about value in this framework, it's not just quality, it's also costs, it's also patient experience, provider experience. Hopefully this will not drive more burnout. We're tracking that as well. There's also functional well-being. There's also return to therapy. And within oncology, it's been done. So Huntsman out of Utah, they did a length of stay reduction hospital home program. And actually they produced the most compelling results of all the hospital home evaluations that I've seen in their program, and it's listed sort of here. So you can see, you know, it certainly speaks for itself, the type of benefits that they got with this program. However, you know, we do believe that post-pandemic, this is sort of also left the barn. So this is as of March. What this calls out on this map is basically all the programs as of March who are doing some hospital home, and it's only sort of gone more as of today. But with new care paradigms, we do think come new liabilities. So we need to be thoughtful about caregiver burden, provider burnout. This is very tech enabled, so that opens health systems up to privacy risk, quite frankly. You know, in the home, the provider, the caregiver are not covered entities. Third-party providers are not covered entities under HIPAA. So there's a lot of complexity that comes with this. And all this is to say, as they went from 0 to 100 through the pandemic, we should be very thoughtful now in how we sort of home grow these programs, keeping attention to these sorts of like novel risks for care in the home, whether it's RPM or hospital at home. So what comes next? I found this quote to be pretty funny, but also true. When we think about the future, we should always be sort of have a frontierist perspective. And when we think about RPM 2.0, you know, so take the existing program, it requires patients to put in vital signs every day, right? And typical chemotherapy regimen is 3 to 6 months, more 6 than 3 months. So that's a long time to engage a patient. And now, can we use passively captured data? Tom has an iPhone. This idea of digital biomarkers. So the heart rate, the sleep quality, the step count. Are these signals, or could they be signals for change in health states, right? So if a patient, and this is all, so we've actually launched this pilot at MD Anderson through a grant. And if a patient, over time, we notice they are walking less, have less screen time or more screen time on the phone, have a higher heart rate or lower heart rate, could that be, based on AI interpretation, a biomarker of something, right? So in this passive world, with their consent, could we now be A, proactive, and be passive in engaging with patients, right? So now, in this world, our vision is we give people Fitbits or they have a smartphone, and if we see a concerning signal, we'll deploy a PRO in that context. So now we get more validated information, sensitive information. If the PRO dings, then we engage them, right? So it's a precision delivery in a virtual care context. And we think this could be scaled, right? It's cheap, it's an app, it's a Fitbit, and really sort of reduces the volume of signal into health systems. That's how we think of it. And so this is sort of where we laid out how we hope to do it at Anderson. And so that's sort of digital monitoring. The last program I'm going to talk about is a program I know Tom is leading here. And our thesis for this is, I mentioned that the workforce and the patient mix will be increasingly millennials in the next 10 years. So what that means is those same expectations of wearables, apps, biosensors, they would bring, to the inpatient setting, actually. And once again, I think this false dichotomy of RPM only makes sense ambulatory-wise, I think is not true. I think the existing workflow for most inpatient care has not really changed in the last 60, 70 years, the industrial production of healthcare. and maybe with virtual care, once again, forcing function. And our use case is actually sleep. So whether or not you're post-surgical, medical oncology, the traditional sleep experience for most patients in hospitals, many will argue, it actually could be better. Deconditioning, frequent interruptions for vital signs, loss of autonomy. And this thing does have adverse sequelae. So Holland Chromotes sort of call this hospital toxicity, playing out all these things listed here. So many things feed into hospital toxicity. We will just focus on loud noises, bright lights, and sleep disruption. And we sort of started a program called Prosper, so promoting sleep, patient engagement, and recovery through a PDSA cycle called Improvement Design. It was powered to about 270 patients to look at improvements in inpatient quality of life due to sleep optimization. We focus on a broad mix of cancer specialties, and by design, it was quasi-experimental. So the way our architecture is for the built environment, each floor is a service, and each floor has 2 pods. So we said, okay, we'll just make one pod, the Prosper Intervention Pod, and the other pod is control. Since bed assignment is independent of intervention, is wherever there's a bed available. So we just sort of use that design, and we powered this program, I'll talk about the program, to quality of life, but as a balancing measure, we looked at clinical outcomes as well. And we co-designed it with each of those specialties. This is what thoracic surgery came up with as sort of people who would be ideal for this program. And this is the workflow. But in essence, the program, we thought of it as one, sleep. So that was monitoring medications. We created a storyboard, thanks to the WashU team, that we gave to patients on arrival. We gave them earplugs, sleep masks. We actually batched care. So for thoracic surgery, they wanted to privilege sort of interruptions, 11 p.m. to 5 a.m. Should you need to go in, it was pragmatic. We gave nurses and the PCAs clip-on red lights when they went to the room. They started putting on the bright overhead lights. And then we also, in parallel, really focused on patient engagement with their care. So we sort of launched a bedside tool that had all this information. This is enterprise-wide, but we sort of did teaching on our program for the MyChart bedside. We created sleep hygiene educational video that we loaded and gave to patients. And then we created what's called structured rounds. So that is on the screen right. And this is what it looked like for the stem cell transplant group. But basically, we told each patient, so we're not prescriptive, but we said, if you could answer all these check boxes during your stay, you are pretty activated around what's happening to you. We empower them to sort of bring these things up at rounds. Of course, the primary team was aware. And then we also created this wall decal, an epic order set to flag a patient who was in the program. So for our results, this is the preliminary results, it was quasi-randomized, but we also then matched on the back end as well. So we got pretty good balance as expected, post-match. And then we saw, so what's in red is significant. We saw that quality of life, sleep, which were powered to, improved in the intervention arm. I will say that sort of 30-day mortality and ICU transfer were not powered to that, so it was not significant. However, sort of it did raise some concerns that we're now going back to look at, do those sort of patient journeys and see what happened to them, and maybe we need to like sort of amend our eligibility criteria to make sure that we're not sort of having an adverse sequela of more ICU transfers. It was not significant, but certainly it jumps out at you when you look at this. So we are updating our protocols to do that. And once we do that, we're going to launch into phase 2 tentatively in January. So it's IRB approved, same quasi-randomized design with this company called Sotera. And now we're going to lay on to the existing workflow, passive capture of vital signs overnight. And also, we're also layering AI algorithms to predict, since we're getting these vital signs higher frequency, predict clinical deterioration in advance. So that is my last sort of like program overview. Thank you so much. So when we think about, going back to my prior quotes, how we move forward in this virtual care space, it really is about powerful implementation of care redesign around the needs of patients. And it's a huge team that supported all of this work. So they're all here. I think any one of them could have given this talk on in placement of me. And it's a journey. We're on it. I think this journey has no end. It's one of just constant iteration and humility and trying to sort of move the needle forward. But we're pretty excited about this journey, and thank you so much.
So our first question is around RPM,
Mhm.
the slides you had. And the question is, are the tech kits recycled for use by other future patients?
Yes. So the workflow is the vast majority get the kits shipped to them. So the kits are shipped to them and they are returned, paid for, prepaid for, back to the vendor, and it's sort of cycled through and then goes back out. So we have like a pool of about 60 kits that are just always in circulation, correct? So the patients don't keep the kits, yeah.
And our second question, I believe may have been in reference to some of the hospital at home slides that you have. And the question is specifically, can you describe the MDA non-ER urgent care platform for cancer patients? Proximity to patients, hours of operation, services, staffing. So can you give us your operating model?
Yeah. So the program is not live yet. And I will say, I'll be remiss to add, it's done with a third-party partner. So in many ways, the effector arm is this third-party entity that is going to help us stand up our program. But the vision is likely, not likely, I know it will be an ER onboarding for two reasons. One, from a culture standpoint, we wanted so I guess a patient comes, there are three potential outcomes. One is not too bad. Here's some interventions in the ER, but follow up in clinic in 2 days. So that's an outpatient paradigm. So that'll be inappropriate for this. Second one is same patient, but maybe has a white count, has a fever, low blood pressure. That's an almost ICU. So that's not appropriate for this program. The third one is maybe someone who comes in, needs IV antibiotics for pneumonia, which if not for this program, we can provide, but stable, looks good, passed the eyeball test. That could be someone who could put in this program. So that decision gate of door 1, door 2, door 3, we think for now, probably for the foreseeable future, should only be made by a clinician. So that's why coming into the ER is like our front door. So there will always be a clinician saying, yes, you should be admitted, but either home or the inpatient tower, that's how we decide. And I'll say also, the CMS waiver requires minimum criteria of satisfaction. So once again, it needs to be established, and that could only really happen if an in-person clinician encounter to make that assessment is sort of part of the workflow. So we have no non-ER. Now, there are many onboarding ramps. So it could be post-surgical, PACU to home. It could be ER-based. It could be ambulatory clinic. I think the commonality is a clinician has assessed and deemed the appropriateness of that care journey. So that's how we think of it. And I'll say most programs have a similar paradigm. Now, if you want to do rehab at home, then you probably don't need that. But that's how we think of it.
Great. I'm going to steal the mic here since I have it in my hand and take this opportunity to ask you a question. In your slides, I noticed Vivify, for example, with your RPM solution, as well as you referenced hospital at home, thinking about a third party to assist you with some of those services. How do you think about third party support as you build the virtual care capabilities? Do you think that that is a viable solution for institutions going forward, just because health systems aren't a logistics company, and thinking through some of the RPM services and recycling those kits, for example, and shipping them? What are your thoughts about partnering with third parties?
So the way the provocative test I typically say is Sunday night, Christmas Eve, 9 p.m., someone needs a stat lab. If a health system can figure out that supply chain redundancy to make that happen, by all means, right? And some health systems may have that, right? So I think Kaiser sort of in-sourced their hospital home program. I think they're working with a third-party vendor, but they've done it in-source before. but most of health systems cannot meet that bar, right? So I think if you can answer, I think that's sort of like, there are many tests, but that's mine. So like, if you can make that happen within 2 hours, which is sort of the accepted standard, or less if it's acute, then potentially. But I think also in many ways, the third-party vendor, you could create KPIs and create MSA, PSAs to sort of like structure it. But I think, you know, hospital home, the long-term sustainability, i.e. payer arrangement, is up in the air, right? The pandemic will end. What happens to this waiver afterwards? So if a health system has sort of allocated all this capital, and I'll say that in going through the vendors, first of all, they're heavily capitalized in a way few health systems can match, to be honest with you, in the time period necessary. And number two is it somewhat de-risks things if you sort of structure it right. And the question is, and also I think virtual care, hospital home care will never be a massive footprint for the next foreseeable future. But as that program grows, I think it's up to health system leadership to say, okay, it's where the puck is moving. Let's begin to transition capital resources to insource this, maybe create a JV, or I think there are many ways to arrange it so that I think it's sustainable and makes sense financially for health systems and the third-party payers, or transition in-house. But I think out the gate, the third-party payer, a third-party vendor who does this every single day, and have the training, have the certification, have the supply chain as redundant at home, I think that's the way to go for multiple reasons. Yeah. Now, how do you make that white label? How do you make it still feel like WashU or Barnes Jewish or everything else? That's a strategic question that we have to also, because people don't come to Barnes Jewish to then have care delivered by some other vendors. You have to make that experience still feel authentically like Barnes Jewish, right? So these are all the things that sort of you have to think about, but they're not insurmountable. Certainly we've reckoned with those as well. But I think that's how we approach it.
Are you far enough along in your hospital to home planning to have a target around your average daily census?
No. So it's gonna be staged. It's gonna be a pilot. It's gonna be deliberately small. Yeah. Okay. And actually, going back, that big map I showed. So CMMI and CMS, they published their experience, their 18-month experience, like late last year in EGM Catalyst. And under the best of conditions, like pandemic, stuff like bed capacity, virtual care, full freight DRG payment for care at home, across 180 at that time when they did the paper, health systems or hospitals, they averaged about 15, right? So it's pretty small end. So I think sort of, and that could be many things, right? But I think approaching this with a staged, deliberate, start small mindset is probably the way to go. Now, I think a useful reference is Mount Sinai. So Mount Sinai had, to my knowledge, the most mature program pre-pandemic. They were seeing about 700 a year, give or take. So that's what it could be. I think that's non-trivial, right? So I think that's what it could be. Probably say, and that model pre-pandemic was very low tech, and I think they'll admit that as well. So you can imagine with a tech enablement, and now it's Manhattan, the certain geography is very compact. But I think a mature program would be low thousands, give or take, if scaled right, mature. So, but I think for us and for most systems, it's a very staged, in oncology even more so, right? So the trajectory of a cancer patient, on a cancer, could be very abrupt very quickly. So I think being staged, intentional, thoughtful, and how you roll this out is key.
On your remote patient monitoring program in this next phase that you're going into, how many patients are you hoping to have enrolled? And can you talk a little bit about how you're scaling your digital health navigators? I love that idea, the digital health navigators. And how many are you looking to have on board for what patient population?
Right, so it's 750 for the formal pragmatic RCT. I think based on that experience, we'll then sort of think about what's the right staffing level, right? So as a reference, we use traditional lay navigation, which is fairly common in oncology. So Gabrielle Rourke from UAB, her work showed that for lay navigation oncology, which is very different, but still it's a good like back of the envelope. I mean, we sort of made the roll up for this program. It's about 200 per lay navigator, right? So our staffing level reflects that. And then we'll see, as the program matures, we could flex up or down, but that's sort of how we're thinking about it.
Hi. So you're not going to be surprised by either of my questions, but in whichever order makes sense, could you talk about how you've thought about how this would apply to rural settings, particularly under sort of chronically under-resourced rural settings?
Yeah.
And related to that, how do we get this paid for? Or under what payment paradigm does this make you happiest?
Right. So I'll take the second one first. I think CMS is many things, Karen, you know this, is as much a payer as it is a regulator and a convener. So as CMS goes, everyone will follow. And I know this administration, and they've written this and they've signaled this, is really keen on total cost of care accountability. That's just sort of where the puck is moving. So the question now will be, how do we get tracks, whether it's nested, sort of like episodic care? So oncology is fundamentally episodic. And so is acute care. How do you get acute care in that type of chassis, right? Whether it's ACO or global budget, which is sort of my research interest. But I think that's how this will be paid for. Now it's up to the health systems to translate that accountability to a blend of episodic and, overall lives, sort of like management. But that's how this is going to go. I think there's a lot of appetite and interest in having this be a case rate a la DRG. That is very simplistic and that makes the most sense. I probably say it would not be one-to-one equivalency. If I was to guess, probably 0.6, 0.7, something like that. Something to support the infrastructure investment that people have to make to build this program, but also not deplete the trust fund. So I think that's how I see it going. For rural settings, that is one that will be tough. I think the Huntsman, Utah experience is very indicative. And the way they did it is one, right size. So for instance, many people sort of the at-home piece, they geofence. So let's say, take Houston, West Houston. If you have a certain number of patients, let's say 20 patients in that area, then the nurses, the EMRs, the techs, the physical therapists who will be assigned to that catchment area live there. So that sort of gets at the staffing, the acuity. That's how you solve that problem. I was saying rural, number one, you have to have a bigger catchment, just the way it is, number one. Number two, I think in many ways, everything comes down to who you select into the program, fundamentally. I think between a staffing model that is local, both in proximity as well as the population. So is your healthcare workforce people that mirror the context? I think that drives trust in this program, number one. And number two, sort of the people you pull into this program, is it appropriately right size for the environment? I think that's how I think about sort of like the rural hospital home. And I'll say that I'll acknowledge Brigham and Women's, they've actually published work thinking about the design of rural hospital home programs. That's very insightful and I think well done. And two, they've launched a pilot for rural hospital home programs. And they've also created a learning network for people think about doing hospital home broadly, but also in the rural context as well. So I think it's an ecosystem building because I think that gets at an equity lens to hospital home. Is it only in urban academic environments with AMCs that have the resources or the people to design these programs and partner with X vendor? That raises equity concerns. And I think sort of your point's well taken, thinking about the rural context and how do you adapt this delivery model to that environment is really critical.
There we go. I have an observation and then a question. First of all, the fact that your sleep program has quiet hours of 11 to 5
Mhm.
is very surgeon of you. In our more humane world of medicine, our quiet hours are 10 to 6,
Yeah,
which hews to the evidence of the appropriate amount of sleep for health.
Yeah.
So, Dr. Surgeon,
Yeah.
just keep that in mind.
So my response to that is the quiet hours, the workflow were driven by the care teams. So we were not
The surgical
the surgeon.
care teams. That's right. I'm positive that's
Yeah.
what happened. But in all seriousness, one thing that we've noticed here is as the COVID surge recedes, although it was exciting to see all the virtual and digital technologies that that crisis sort of facilitated, we're seeing a snapback. And I would actually note that the snapback is not from as much the patients who now, as you pointed out, continue to indicate interest in digital engagement, but it's from the care teams and specifically the physicians. And we're often seeing now that when we offer virtual visits, sometimes the patient will schedule one, then the provider changes it back to an in-person. And a couple of things are maybe there, but I'd love your thoughts on that. One is there is a lot of worry from our physician colleagues, and myself included, that if we start monitoring the heck out of people and we get this inbound, this data deluge, it's going to be enormously disruptive and additive to an already busy work life. I think there are approaches to manage that. And you talked about a few, we have a few built in on how we triage those alerts. But I also think there's a less articulated, but still real thing about physicians are comfortable with the prior way they deliver care in person. And I think there is probably some natural skepticism about, can you get the kind of engagement, the kind of assessment, the kind of quality of care that occurs in person through a screen or some other sort of digital interaction mechanism? So just be curious if you've seen that or what your thoughts would be about how to address that.
Yeah, so I have a 1 hour response to that, but I'll give you the 5-minute version. So one is, I think path dependency is very strong in healthcare. So yeah, hence the snapback. Number two, I think that gets to the implementation side of things. So did we really, once again, it was a 0 to 100 COVID, but did we thoughtfully deploy these things from a support? So I'll give an example. So a lot of, in the beginning, for many people, my virtual sort of like clinic encounter kind of sucked, right? Sort of like, patients don't know how to use a microphone. I'm looking at the screen, so there was a whole bunch of like learning, soft and hard, that needed to happen to get us, make this high quality for everyone involved. That just did not happen because we had to like turn everything on. And outside Anderson, kudos to our team, we had a whole education on how to do a website manner, they call it, right? So like how to have that. So I think there's an implementation issue on the provider side as well. Like what I do with like a very friction heavy encounter, I could just like do it in person. So that's number two. Number three is, I think the cat's out of the barn. I think virtual care is here to stay and people move with their feet. So, and the millennial setup is so true. So now many people have meaningful relationships that are entirely virtual, right? And who am I to say that's less or more valuable than our friendship, right? So, but I think people are gonna demand that, and I think health systems will have to meet it because there's an economic, moral imperative to do that. And lastly, I alluded to this, the evidence base was not robust. It really wasn't. I mean, RPM in cardiology, not a home run, right? People that's systematic review meta-analysis has shown that. I think there's a healthy, honest, appropriate skepticism that, this is not, sort of like the ground truth and we need to see it. So I think that's where it gets to experimentation. Now, our culture at Anderson is they want to see a trial, right? So we're doing a trial to generate that evidence, basically say, this is why we should do this. This is why we should accept that fiction. And I think if you put in front of people compelling data that this does work in this context with this workflow, I wonder if the resistance will really decay if you pull that forward. But that has not been done. And I think the onus on us is to generate that data to make it more compelling. I'll say right now, for physicians, A, it's not compelling. B, the workflow is suboptimal. And C, path dependency. So that's sort of how I think of it.
We've got another question from our online audience. How vast is the MDA catchment, and what % of that catchment is eligible for the hospital at home program?
So the catchment is typical for most. So it's about, and you can define the catchment by windshield time, define the catchment by zip codes. I think what we do is not super relevant. I think the idea is whatever catchment you create, sort of for care escalation, it's sort of not a sort of long journey. So 45 minutes is of how we're thinking about it. Now that differs based on the geography. So if you're in a rural area, I'll probably say that catchment will like to be amended appropriately. So that's the one. And what's the second thing you said? What do you mean? Sorry. I know you didn't ask the question, but what do you mean by eligible? So yeah, correct. Enough, pretty big. I mean, so I'll say our volume is pretty incredible. So back of the envelope, for the diagnosis we're thinking about, for the catchment we're thinking about, for just solid tumors, so not surgery, not liquid tumors, the thousands. So yeah, so it's pretty, so more than enough to support a program.
So one thing that I think is pretty unknown in the sort of intersection of payment and care delivery is how you should define an episode. So surgery is an episode.
Yeah.
And chemo is an episode.
Yeah.
Heart failure is arguably not.
Yeah.
Pneumonia is an episode, right? And I think one of the reasons that it's been difficult to figure out how to integrate both virtual care and team-based care is because you have to kind of cross-reference the axis of like,
yeah,
I don't know, chronicity and the like who's involved in the care, right? So you have some pretty clean start points with chemo or surgery or something like that. So when you are thinking about this broadly, does it keep going? Are there people that we just sort of, they aren't sick enough, they aren't well enough, and they aren't in enough an episode that this never goes to? Or like, how do we think about sort of all of these digital things beyond a chemo or surgical case?
Great question. So I think one, if I was to tackle that question, I'll do like I do everything else. So sort of take a typical, so fundamentally you have to be condition specific. So that's the first sort of cop answer I'll say. So let's take pneumonia. I will say, like most episodes, I'll define it by an acute phase, a transitional phase, and episode end. And we can look at sort of health resource consumption over an PPCI-esque, right? 3 month, 30 day, whatever is appropriate, and see how things break down and sort of create windows, acute, transitional, based on how you're using services. I'll say for a pneumonia episode, I'll say 7 days is acute, right? I'll still make it a 30-day bundle, but I'll say the first 7 days is acute. And during that time, and everything's sort of modular, we can flex up or down, but during that time, I'll deploy twice a day. I'll deploy remote patient monitoring, 24/7 surveillance, right? Now, as you get to day 8, 9, 10, and if the trajectory supports that, then I'll de-escalate to once a day visits and everything else. So that's sort of how I'll think about it is, okay, how are you using services over, and I think 30 days should capture most acute things, all things being equal. Okay, then I'll just say, okay, then there's the acute, there's a transition. And I think historical, sort of like, you know, canonical, like how we manage people on the inpatient should translate to the outpatient, right? So I think because it's hospital at home, it's acute inpatient care. So I think there's some portability on how things play out here to what plays out there. That's probably how I'll think about it. But I've never actually thought about that. But that is something that we need to wrestle with.
I
Karen
think it's
always
part of
asks
why
the best
well,
questions.
I just think it's part of why the transition to digital in the outpatient setting has been so clunky.
Yeah,
Because you just throw it in and you're like, well, which of my patients that are coming to clinic today, or which of the patients that are, we don't have population health. We don't know who our patients are. How do we
Right.
pick who to enroll in so COVID sort of threw everybody into these virtual visits and in a arguably random
Yeah,
sense.
yeah.
And now we get to go back and
And see,
say,
yeah.
for whom did it work? And you have a paradigm you put together for pneumonia. And I would assume that we could similarly go back and say,
Yeah.
okay, if we do have a population, for whom do we deploy which of these
Right.
Anaeze invented models?
And the way I'll even double click on that is not so much for whom. So I'll say virtual care is not for every patient. Even for those patients who it's appropriate for, like I know, high tech literacy, whatever criteria you make up, it's not for every encounter of that patient, right? So there's a lot of variation across and within people and segments. So I think the art is really being thoughtful and saying, okay, for this patient, for this kind of episode, virtual care makes sense, and why? Because I would imagine, I think there's this false dichotomy that it needs to be virtual X and then built environment Y. No. I think there's a lot of fluidity. You can imagine, so take RPM, for instance, right? So like you go from RPM to care at home to if it goes in the wrong direction, goes to inpatient environment, or it could go back to RPM. So there's this like fluidity as you go across levels of intensity of involvement. So I think being that modular is how this should go within and across different patients. That's how I think of it.
I think we've also learned a lot from our design colleagues about how do you think about the journey?
Mm-hmm.
I think we often think about what's this episode, what's that episode? But from a patient's point of view, the timeline is their life, right? And things ebb and flow. You talk about that with the rising risk. We've also learned a lot from the design community about personas. And personas are bigger than how we categorize phenotypes of patients, which is important. We think about demographics and clinical conditions. Personas also include behaviors and preferences, the way people think about their healthcare, the way they interact with it, and thinking about how all that comes together in the interplay of digital technologies to support it where appropriate.
Yeah.
It's an incredibly complex multivariable equation, but I don't know, I think this community is up to the task.
Yeah. One thing one stat that someone told me that just sort of dropped my jaw is the typical American spends less than 10 hours cumulatively per year with a physician.
Yeah.
Like I was just like, wow, I'm this individual. He would know actually, and when he told me that, I was like, wow. And when you think about the patient journey, is you're right. What we see is such a hyper compressed, supercharged, but small part of the rest of their lives that's very disruptive, incredibly disruptive. The parking and everything, just like very disruptive. And I think appreciating that patient journey is just huge. And I think even more so as you now go into their context and deliver care. But yeah.
That's right. Well, we obviously could talk for hours more, but we've come to the end of our time. So I appreciate everybody in the room and everybody on the screen. And most importantly, I appreciate you, Ani. So thanks for coming out and sharing your thinking. It's wonderful. Please join me in thanking him.